My name is Ryan Bresnahan. I am the Training and Operations Officer in the Emergency Response Unit at International Medical Corps. I would like to introduce our guest speakers for today's session, which is called Perspectives of the COVID-19 Pandemic. We have two subject matter experts in the fields of emergency medicine and medical anthropology, each with a unique perspective of how the pandemic is impacting society's health here in the United States. So our first speaker, Dr. John Fogel, MD, MBA, is an assistant professor of emergency medicine at the Alpert Medical School of Brown University with expertise in medical simulation, wilderness medicine, disaster preparedness, trauma management, and international emergency medicine development. Dr. Fogel has 30 years experience as a clinician and educator, frequently works and lectures internationally, and is trained and board certified in both emergency medicine and internal medicine. Our second speaker, Dr. Kevin Bartosh, PhD, is a medical anthropologist and implementation scientist who has worked throughout the world on infectious disease and epidemics, including Zika and Ebola. He is currently a consultant and affiliate faculty member of the Center for One Health Research in the School of Public Health at the University of Washington. He is the editor of two books, Locating Zika and One Health, Science, Politics, and Zoonotic Disease in Africa. But first we get started, I'd like to say a couple words about International Medical Corps for those of you who might not be familiar with our mission. So we are a global humanitarian organization dedicated to saving lives and relieving suffering. Established in 1984 by volunteer doctors and nurses, we are a nonprofit with no political or religious affiliation and now have more than 7,000 staff members around the world, more than 90% of whom are local. Our mission is to improve the quality of life through health interventions and related activities that strengthen underserved communities worldwide. With the flexibility to respond rapidly to emergencies, we offer medical services and training to people at the highest risk, always working to strengthen local healthcare systems and promote self-reliance. So in alignment with our mission, International Medical Corps is responding to the COVID-19 pandemic around the world, deploying medical supplies, training health workers, setting up triage and screening sites, and more. Together, we are ensuring that people receive the medical care they need while keeping health workers safe. Here in the U.S., International Medical Corps is increasing patient capacity at hospitals. We are delivering training and information series for health workers, and we are ready to deploy emergency medical teams. So without further ado, I would like to turn it over to Dr. Fogel for his presentation, COVID-19. What do we think we know? Dr. Fogel?
Thank you, Ryan. Hello, everybody. I want to preface my talk by stating that I changed the title a few days ago and tweaked it again this morning as this virus and all the information surrounding it is a moving target. My focus today will be on what we think we know. Things are changing so rapidly the last few weeks and even days. Because of this, I had to make some edits to this presentation even this morning. Next slide. COVID-19, which was initially called a novel coronavirus, is an RNA virus related to SARS and MERS-CoV, which were also at one point in time each originally named a novel coronavirus. Corona means crown, and if you look at the physical structure, you can understand why they all are designated as coronaviruses. Unlike the other two, COVID-19 is both more transmissible and less deadly, which is part of the reason why it has become a pandemic, and the other two were able to be stopped. Next slide. Most of you know the classic symptoms for COVID-19. They are highlighted in the graphics at the top, but as clinicians, we all know that many of our patients present without classic symptoms of a disease. I have highlighted a few less typical symptoms because they are receiving increased attention. Specifically, a loss of smell and taste may precede the classic symptoms and could be an early warning signal for COVID-19. I have already taken care of patients who presented in cardiac arrest, were resuscitated not always with the best practices regarding PPE because COVID-19 was not suspected and the patient subsequently tested positive. This is scary. One colleague of mine took care of a patient with a GI bleed that tested positive, and I've seen other patients with primarily GI symptoms who subsequently were confirmed to have COVID-19. The take-home lesson is as follows. Assume every single patient that you see is COVID-19 positive. That means you wear appropriate PPE if it is available with each patient encounter. We will talk more about PPE shortly. Next slide. To understand appropriate PPE, one needs to understand the modes of transmission. There are two primary ways in which COVID-19 is spread. One is through droplets, the other is through contact. That means precautions must be taken for both. A classic viral disease that is transmitted via droplets is influenza. COVID-19 is more transmissible than the flu. It's also deadlier. Droplet transmission PPE is a surgical mask, which your patient should also be wearing because typically droplets do not go further than 6 feet. Hence the 6-foot social distance rule we've all been hearing about. Healthcare workers need to avoid any possibility of transmission via one's mucous membranes. There is one significant exception to droplet transmission. This occurs when the droplets can be aerosolized and where airborne precautions would be needed. Examples of diseases requiring airborne precautions are TB, measles, chickenpox. It is only with aerosolization where the concept of a negative pressure room would potentially be beneficial. Airborne precautions would mean an N95 mask and an eye shield or goggles or the use of a PAPR. As an emergency physician, this would primarily mean during endotracheal intubation. In our busy urban academic medical center emergency department where I work, BiPAP and nebulizer treatments and even bag valve mask ventilation are prohibited because they too could aerosolize the viral particles. Contact precautions are trickier as it's still unclear as to how long COVID-19 virus particles can live on and be transmissible from contaminated surfaces. There are reports that they may live for as few as a couple of hours, maybe as long as many days. Nobody really knows, and nobody knows how long they may be transmissible. That means you must wash your hands almost all the time. It also means you should wear gloves during every patient encounter. Next slide. I must admit that I've always washed my hands in the wrong way. I'm way too fast, a couple seconds. This slide emphasizes that good hand hygiene means 20 to 40 seconds of compulsive and thorough hand washing, depending on whether you're using soap and water or an alcohol-based sanitizer like Purell. Next slide. Another general guideline, which is extremely hard to do, is not to touch your face. We kind of do it a lot. Dr. Sarah Cody in this picture is the health commissioner of Santa Clara County in California. And she said, quote, "One way the virus is spread is when you touch your own mouth, nose, or eyes." And then she went on to turn the page and place her finger in her mouth to help do so. Great, right? A no-touch policy also means no hugs, no handshakes, no physical contact, and maintaining at least 6 feet of distance when possible, which of course is never possible when you're examining a patient. Next slide. Risk factors for COVID-19 are not 100% known and seem to be changing. It used to be thought that the elderly, which somehow has been defined as older than age 60, which kind of upsets me a little bit, along with comorbidities were the primary risk factors. Certainly somebody with underlying heart disease, diabetes, COPD seem to be at particularly high risk. In addition, it appears that people who take ACE inhibitors or angiotensin receptor blockers may also be at increased risk. If you have a patient who is taking one of those medications for hypertension, you may want to change it to an alternative. Sadly, younger people in the 20 to 40 age range, especially in the US, are also getting severe disease and are dying. They think that vaping and regularly smoking may be correlated with disease severity. And lastly, and unfortunately, we as healthcare workers are probably the most at risk. Next slide. I'm going to highlight a COVID-19 timeline. To the best of our knowledge, the first case occurred in the beginning of December in Wuhan, China, and a novel coronavirus was identified as the cause in early January. The initial spread was in mid-January in Asia. The first case in the U.S. was diagnosed just after that time. And at the end of January, the World Health Organization declared this novel coronavirus to be a global health emergency. Italy, which has been particularly hard hit and has the highest death rate, didn't get its first confirmed cases until January 31st. Next slide. This particular slide looks at clinical severity estimates and comes from a World Health Organization document at the end of February. It is entirely based on data from China. There's reason to believe that the clinical severity estimate in the bottom portion, the so-called mild part, is actually a larger percentage. That is based on the number of asymptomatic or minimally symptomatic individuals at the beginning of this disease outbreak in China who were never tested. That means that the severe percentage is likely less than 10%, and the critical percentage may be as low as 2 to 3%, but that's still worrisome. Next slide. We won't really talk about case definition in any detail. I was a consultant for 2 weeks for the World Health Organization in Fiji and Tonga until early March. The case definition has been a moving target. Travel history used to be the key. The initial focus was Japan, and then it was South Korea. And the initial focus was China, then South Korea, Japan, then Italy, then Iran, and then any travel at all. The travel history is now irrelevant as community spread is almost everywhere in the world. Again, as I emphasized earlier, any patient you see should be assumed to have COVID-19. That does not mean you need to test them all. It simply means you need to protect yourself. Next slide. That brings us to our February timeline. The highlights are the Diamond Princess cruise ship quarantine in Japan at the beginning of February. We'll come back to that later. In addition, the Chinese whistleblower, who was only 34 years old when he passed away of COVID-19, was an ophthalmologist. He's shown in this photo here. The other highlights in February also include the World Health Organization officially changing the name from novel coronavirus to COVID-19. The CO stands for corona, the VI stands for virus, the D for disease, and 19 obviously for 2019. Next slide. Getting back to Fiji and Tonga, my focus while in Fiji was designing guidance for the Pacific Island countries. Specifically, I focused on protecting healthcare workers and trying to keep the hospitals free of disease. The general plan was to set up a screening area, which you see in the bottom right, outside of each hospital or healthcare facility. A patient with suspected COVID-19 would be sent to a specialized unit or facility staffed by a specialized roster of volunteer nurses and physicians. All other patients would be allowed to enter the hospital and go through the typical triage and treatment processes. This is especially important in limited resource environments, such as in the Pacific Island countries. While in Tonga, we trained physicians in hand washing, PPE, screening, and case management. Tonga is a country of about 100,000 people, has approximately 50 doctors and only 3 ventilators, with only 2 that work. They cannot afford to have COVID-19 patients in the hospital. They cannot afford to have healthcare workers get sick. Even in Ebola, many of the deaths that occurred were preventable from diseases other than Ebola. If any country where healthcare workers are unable to perform their duties because they get ill, people will die from treatable diseases. Next slide. This is the first PUI, person under investigation in Tonga. She was young and a returning travel from Australia with classic symptoms. I was asked to actually assess her at one point. They've had 7 subsequent PUIs. None have tested positive to date. They've shut down all flights in and out of Tonga and all cruise ships coming in. They are better positioned than some of the other Pacific Island countries to do that. In an interesting way, they're even better prepared for prevention and containment than we have ever been here in the U.S. Initiating such policies in the U.S. would be hard, if not impossible. Now it is too late. Our goal in the U.S. is a mix of further containment and mitigation. Of note, there are now 5 positive patients in Fiji, which is a much larger nation, and a few of the other Pacific Island countries also now have confirmed disease. The complicating feature for all these countries, and especially Tonga, is that testing is generally sent out to Australia or New Zealand, and with ongoing international flight restrictions, getting testing done will become ever more delayed and problematic. Next slide. The data on healthcare workers in the U.S. and in other parts of the world is also worrisome. This is an article from the Boston Globe last Friday, which already documents 160 healthcare workers in the Boston area who have tested positive. You can see the data for a few of the other countries. It is believed to be an underestimate. I'm aware of at least 2 positive cases within my own group as emergency medicine friends, as well as emergency medicine friends around the U.S. And there are reportedly 5 or 6 emergency medicine residents at the University of Massachusetts who also have confirmed disease. I strongly abhor comments that healthcare workers got this in the community. My life has been work, being isolated from my family, pumping gas only once, and a rare trip to the supermarket performed ninja style in each situation involving excessive hand washing and hand sanitizer use. If I get COVID, it will be because I got it at work. It will be because healthcare workers in the U.S. and in other places are needing to compromise infection protection and control with inadequate PPE because of inadequate supply that is being rationed. We have been creating a policy to meet the existing supply chain. It's not right. Next slide. The World Health Organization specifically says that when you're done with your mask, it should be disposed of. We are reusing single-use masks, which we should not be doing, and using them for days at a time, placing them in a paper bag between each day of use. We are actually running out of equipment. We have less than a 2-week supply of N95 masks. Next slide. I see more inappropriate mask use out in the community than I do appropriate use within the hospital. Next slide. The U.S. has become a limited resource environment when it comes to PPE. Some healthcare workers are using trash bags as gowns. In truly limited resource environments, such as parts of the Philippines, healthcare workers have had to significantly improvise their PPE. Next slide. This data is tracked throughout the day at Johns Hopkins. This is from just over 1 month ago on February 24th. At the time, there were less than 80,000 cases around the world, and well over 90% of them were in China. The U.S. had only 35 documented cases at that time, just over a month ago. This is partially because of a lack of available testing. Next slide. This is from 8:30 this morning. You can also see the link if you want to look at this site and haven't previously. The U.S. is number 1. We were in 8th place a week ago and surged past China this past Thursday. Worldwide deaths a month ago were less than 3,000. Now they are more than 35,000. It is just the tip of the iceberg. We are still under testing the U.S. by a dramatic amount. Next slide. Let's discuss the March timeline. At the beginning of the month, the World Health Organization stated the death rate was 3.4%. On March 11th, the World Health Organization declared COVID-19 a pandemic. There are 177 countries with confirmed cases. The worldwide caseload has surged from breaking the 500,000 mark to surpassing 750,000, a 50% increase in just the past 4 days. It's incredible. Next slide. Let's take a quick look at the U.S. Our first case was in mid-January. Our first death at the end of February. Disney closed down and the sports world stopped on March 11th with the cancellation of all sports in the U.S. We are now the world's epicenter. If New York was a country, it would now rank number 6 in the world. Next slide. Our goal has been to flatten the curve, thereby hoping to avoid a massive surge in cases and perhaps contain and prevent further spread. While this is an admirable policy, there is no question that it was implemented too late. Any measures to truly flatten the curve should have been initiated over 6 weeks ago. Next slide. Where I work, we have been slow to test. Our first case in Rhode Island was March 1st. Our emergency department volumes have plummeted since. We still are not testing enough. In Rhode Island, we have done a quarter of the number of tests per capita as compared to New York State. The image to the left shows the majority of the patients who are waiting to be seen on Sunday, March 8th, and they were suspected cases. Even then, testing has been grossly inadequate and underestimates the actual number of cases in Rhode Island. Restrictions by the governor, while perhaps appropriate, are too little and too late. My hospital has created a negative airflow pod just last week at a large expense, which would suggest airborne precautions. The science would suggest otherwise, and we are wearing surgical masks in that area. We have a radiology room that I have historically gone into many times every shift to discuss images with our radiology team. Now it is locked. They're scared of us. Next slide. A quick look at case fatality rates show how deadly other viral diseases have been over the last century. In order from the top left down, there is smallpox, polio, influenza, SARS, Ebola, and MERS-CoV. Next slide. What is the case fatality rate for COVID-19? The experience in China suggested approximately 4%. The World Health Organization said it was 3.4% at the beginning of March. There is reason to believe that the actual case fatality rate is less than 1% and no more than 1.5%. One example is South Korea, which aggressively tested early on and has a case fatality rate of 1.5%. This percentage may be higher than the reality because they probably missed asymptomatic and minimally symptomatic individuals. The best example is the Diamond Princess cruise ship, which was quarantined off of Japan. I don't know if any of you have ever been on a cruise, but a typical cruise ship passenger is not the epitome of good health. They're often elderly, and they are more sedentary than the average human being. Every passenger and staff member on the Diamond Princess was tested, and of the 712 COVID-19 positive patients, only 10 of them have died. That means a case fatality rate of 1.4%. The denominator is real, and if anything, the case fatality rate is likely overstated based on the protoplasm of the typical cruise ship passenger. Next slide. Let's talk about treatment. We're going to keep this relatively simple. The general recommendation to our patients is to stay home unless you're really sick with dyspnea. Patients sent home can take over-the-counter medications with an emphasis on acetaminophen rather than ibuprofen or NSAIDs. There is some concern that NSAIDs may be harmful. If you see a patient and are able to test, a nasopharyngeal swab should be performed. This photo is actually flawed because it should be done more safely than this. The patient should have a mask that covers the mouth entirely. The provider performing the test should be wearing appropriate PPE. So a surgical mask, a face shield or goggles, gloves, and ideally a gown. In addition, one can approach the patient from the side, further reducing the risk to the person collecting the specimen. Please keep in mind that a false negative rate of up to 1/3 can exist. If somebody is hypoxic or septic, they're treated in a typical fashion with early broad-spectrum antibiotics. Lastly, co-infection rates are not insignificant, and somebody can have influenza or another virus and have COVID-19 as well. Do not let your guard down just because of a positive flu test. Next slide. Critical care management can be particularly challenging in any limited resource environment, especially if there's not enough PPE or ventilators. Please remember that if you use BiPAP or CPAP or bag valve mask ventilation or nebulizer treatments, then you are aerosolizing the virus and need to take appropriate airborne precautions. The prognosis for intubated patients is not good, with fatality rates being as high as 86% in China. Rather than RSI, some people like the term delayed sequence endotracheal intubation. My preferred intubating meds are shown on the slide. You need to be wearing full PPE or PAPR if you're going to intubate. Try to minimize the number of people in the room. I usually keep a maximum of 3. Finally, once the patient has been successfully intubated, make sure you have the appropriate order of equipment, including a viral filter, to make sure that you don't cause further airborne spread. Next slide. I want to touch on some ethical issues. We do not have enough ICU beds or ventilators in the U.S. The shortage will be really becoming much more serious this coming month. The ethical challenge will be to determine how to triage limited equipment. So many gut-wrenching questions and such a big challenge for healthcare providers who may ultimately have to decide who shall live and who shall die. Next question, next slide. There's been a lot in the news over the last few weeks about experimental meds. I want to emphasize that there are no randomized controlled trials that show that these medications actually work. They may. Trials are underway now. Any evidence now is entirely anecdotal. These medications include chloroquine, which was an anti-malarial, which has been around since World War II, plus azithromycin, or a new antiviral drug called remdesivir. Chloroquine is currently in short supply because of hoarding, mostly by doctors. Lastly, hopes for immunization are at best a year to 18 months away. We do know that COVID-19 mutates, but it does not appear to mutate as quickly and as drastically as the influenza virus. That means that there is hope that immunization may offer longer-term immunity and with more effectiveness than the flu vaccine does. Will this ever disappear? Can it be eradicated? Will it become an endemic disease with sporadic flare-ups for years to come? We don't know. It is not clear if you will develop long-term immunity if you have the disease, but there exists at least the possibility of relative immunity. Next slide. My take-home points are: assume everyone is COVID-19 positive, not just your patients. Wash your hands again and again and do it thoroughly. Use the 6-foot rule. I do not like the term social distancing. I prefer physical distancing. I've actually seen people become more socially involved with others, such as meeting virtually over the internet. Droplet precautions means a surgical mask with some form of eye protection, and any invasive respiratory procedure, such as intubation, means an N95 mask or a PAPR. Next slide. Lastly, the best thing your patients and your family can do, and we all can do when we are not at work, is to stay home. Thank you, everybody. Stay safe. Over to you, Ryan.
I would like to turn it over to Dr. Barash for his presentation, COVID-19, Social, Cultural, and Political Realities and Their Implications. Over to you, Dr. Barash.
Thank you. So we know from history and from more recent examples like Zika and Ebola that pandemics are as much biological and medical as they are social, cultural, and political. Pandemics are exceptional events. They make the familiar unfamiliar. Routines are no longer reasonable, and culture itself becomes malleable. Although many people listening will be responding clinically to COVID-19, seeing patients in the clinic, the ER, the ICU, COVID is affecting, in some way, nearly all aspects of human life on Earth. Nearly 2 billion people are currently in some form of movement restriction as the virus spreads across the globe. The situation is changing rapidly. There's a lot to say, and we're all actually living in this together. What I want to do here as a medical anthropologist and implementation scientist is to highlight some of the critical social, cultural, and political issues I have observed over the last dozen weeks or so in the US and internationally. Next slide. So there's a long anthropological literature on how we use the language that we use around exceptional events shape the mental models that ultimately inform our actions and inactions. And possibly the most common one is the war metaphor. It has a long tradition in this regard, especially in pandemics. Oh, sorry. Next slide. Pardon me. Great. So pandemics are often framed as wars and battles that are fought by soldiers on the front line. And this can be a very useful metaphor for clinicians and logisticians in the rush of the emergency, but it raises important questions. War relies on strategy. What is our strategy? War requires ethical trade-offs. Are we aware and prepared for these? War polarizes society, and it can also be used to centralize authority. Society outside the ER and the ICU needs other metaphors, ways of expressing and understanding what is going on. two important ones have emerged. The first is Flatten the Curve, which started around March the 8th. It expresses the consequences of society-wide inaction, scenario 1, with the substantial sacrifices of the many needed to ward off health system collapse and desperately save lives, scenario 2. A second metaphor is caremongering, which is a turn of phrase against the panic and fear that many are feeling. It's an expression of positivity used to describe the overwhelming efforts of communities to show resilience and mutual support. Next slide. Related to the framing of COVID as a war, the pandemic is also presented as a race against time. There's talk of exponential growth rates, doubling every few days, that delay is our enemy, and that a few days can make all the difference. It's also portrayed as a race against nations, a geopolitical event that will influence global diplomacy and the balance of power. COVID reflects different cultures of decision-making, of science, and of the organization of health systems. In less than 1 month, we have witnessed the epicenter move from Wuhan to Italy to New York City. The US has now overtaken, notice the terminology, China in total cases. Policy responses in times of exceptional events happen with lots and lots of uncertainties. Broadly right now, I see 3 different approaches that are not mutually exclusive, and there's lots of variants of them, which I don't have much time to get into. The first is the use of full or partial lockdowns, which are really an expression of being overwhelmed. It was called the nuclear social weapon in China, when nearly 800 million people underwent some form of lockdown for 2 months. The images that the government used to mobilize the population drew on 1940s Maoist slogans. A whole new infrastructure emerged of food deliveries, work environments, a healthcare system, and surveillance. We're seeing some variants of this around the world right now. The second key component of policy response relates to contact tracing. And if we look at the countries that have implemented this the most effectively, most of them have institutional memories from SARS in the early 2000s, or in the case of South Korea, MERS in 2014, 2015. This is a proactive approach: test, isolate, trace. It's based on a ground game. The third policy response, which the Dutch and Sweden are implementing, is a so-called herd immunity approach, which is basically an idea of having a more controlling the infection to spread, not being as proactive, having partial or lockdowns or partial policies for contact tracing. Originally, the UK tried to implement this approach, but there was massive public revolt in some ways in the media and in the public health community against that, where it was accused of being a heartless approach. Next slide, please. So policy responses, lockdowns, contact tracing, herd immunity, are informed by disease modeling, which has taken center stage as we struggle to understand many uncertainties associated with the virus. We've seen many disputes between journalists, epidemiologists, and others. Who has the credentials to inform the government? What are the shortcomings of each model? And actual data is thin and emergent. In parallel, we see an enormous amount of international collaboration between scientists who are communicating on Twitter, in preprint journals, sharing samples, and actively engaging with the press, pulling all-nighters. Now, data shapes public perceptions, attitudes, practices, and health system planning. And if we look at the United States, our preparedness plans, including in the Seattle area where I live, actually never accounted for a failure in testing, as we saw with the CDC and the FDA debacle. Now, Neil Ferguson's model from Imperial College showed basically that if, in the absence of public health interventions in the United States, 80% of the population would be infected in 2020 with over 2 million deaths. And this model was absolutely essential to jumpstart the White House's Slow the Spread campaign. Next slide, please. So COVID is also revealing fissures in the social fabric of America during an era, decades in the making, of extreme political polarization between Republicans and Democrats. The virus discrimination follows these fault lines. If we look at For example, high-risk prison populations. We have over 2 million prisoners in the United States. More than half are nonviolent offenders, and they're disproportionately African-American. Many households live paycheck to paycheck in the gig economy or as blue-collar workers, and an estimated 40% of Americans lack $400 in savings for an emergency. COVID has been deemed the loneliness pandemic by the Dutch king. In the UK, elderly people have been asked to self-isolate for 4 months. People are already... Oh, I'm sorry. I think this is the wrong slide here. Can you go next slide, please? There we go. Great. People are already bowling alone, to use the title of Robert Putnam's famous book about the decline of American community. But now we are being asked to avoid the bowling alley altogether. So we've seen a proliferation of cultural hashtags on Twitter that are reflecting various anxieties around the epidemic. This includes things like Kung Flu, which represents a discrimination and cultural distance with Asian Americans. And also the hashtag Corona Party, which is mocking the selfish behavior of spring breaker college students on beaches in Florida. Finally, we're also seeing intergenerational conflicts being expressed in cultural fora. The idea, for example, of boomer remove, which is a sarcastic jab by millennials at their sense of economic disempowerment compared to the boomer generation. Next slide, please. So in an epoch of American abundance, what some commentators have termed a new Gilded Age, we find the national conversation focused on shortages of 75% masks and toilet paper. There's a bigger conversation going on here between public health, economics, and inequality. Above all else, American political debate is dominated by the health of the industrial economy. At the same time, about 80 million people have no or inadequate health insurance. So quotes like, "To win the war, we need to sacrifice the economy," or Bill Gates' recent comment, quote, "No, there's no middle ground between the virus and the cost of 6 to 8 weeks of lost business." These are met in some quarters by denial, delay, resistance, and counter-arguments, such as, to quote Fox News, "We can't close America indefinitely." The public health argument is also, at times, simplistic. If you look at the Ferguson Imperial College model, it did not account for the social and economic consequences of lockdowns and social distancing. How they will play out in the real world is a matter of urgent attention. The virus is killing people. It's rapidly overwhelming the health system. But a wrecked economy with 3 million newly unemployed in a few weeks will also have horrible health effects. As New York City becomes ground zero, as death cases rise, America as a nation is going to revisit the 9/11 memorial. There will be a process of collective trauma as people make sense of why this happened, especially as healthcare workers sacrifice their lives. Next slide. Words and symbols matter. They are the mental models by which we approach the world, and they have a major influence on public trust. The WHO has used the term infodemic to denote the deadly relations between information and action. Wrong information gives wrong action. And there's a desperate need to address mis- and disinformation. Now, some of these are very simple and straightforward, like the idea that children or young adults are not at risk, or clarifying the fact that chloroquine has not gone through clinical trials. But others are more difficult. Rumors, in effect, reflect deep social anxieties, and throwing information at them does not always work. There's often an internal logic to them. So take, for example, the idea that coronavirus is caused by 5G. This actually reflects legitimate concerns about current safety standards around cell phones, their link to cancer, a lack of trust in big business, concerns about net neutrality, and the future of the automation economy. So panic and fear proliferate in a vacuum of facts. Trust, dialogue, and the acknowledgement of uncertainty. And we can ask, well, who should we trust? And who determines what is mis or disinformation? Next slide, please. So what is the public being asked to do? We're being asked to suspend our connections. Like Ebola funerals, we have to unlearn and relearn our social lives in a moment of immense disruption that is likely to go on for many, many months. So to do this, we are negotiating these instructions to practice social distancing, which is really a form of physical distancing while remaining socially close, and this is seen as a form of social solidarity. Next slide, please. So hashtags like StayatHome, It's a call for solidarity at a distance. We're in this together. Make responsibility go viral. These are some of the discussions going on. And this is driven by a palpable empathy with the overwhelmed health system and the sacrifices in the ER and the ICU. You see this in Italy with doctors, older physicians coming out of retirement, moving images of self-sacrifice. But what does stay at home mean? Can we really save the world by watching Netflix? People are asking. What about going to the park or petting a neighborhood dog or using plastic from the grocery shop or going into childbirth or wearing masks? The public has many questions, and in many regards, they're confused. Also, if you look at the WHO's report from China, it showed that 75 to 80% of transmission occurred within the household. So how can we do home care? Furthermore, we need to ask the question, who cannot easily stay at home? There's the first responders, the essential services, which now include the grocery workers and truck drivers. But what about children without the internet? Single-parent homes, the homeless, the crowded Bronx apartment blocks. Can everyone stay home? Next slide, please. So as much as we see musical flash mobs on Italian balconies and Facebook neighborhood support groups, we're also seeing healthcare workers without PPE and staff having to consider triaging patients' access to ventilators to decide who lives and dies. And we're all witnessing this from the comforts of our living room. Most staff in the United States have never witnessed a significant infectious disease outbreak, and many public health departments struggle with things like syphilis surveillance. A whole system is struggling to emerge. Medical students are urgently graduating. Telemedicine is being propelled into the limelight, and mobile clinics are emerging. What legacy is this going to leave? Next slide, please. So the thing about social solidarity is it cannot only be voluntary in democracies. Some people are going to break it. China's lockdown was driven by an autocratic government that sometimes involved dragging people from their homes and tracking their movements using apps. The hashtag COVIDiot has emerged as one way that Americans are shaming and blaming each other. Things like, oh, well, I'm going to get one more workout at the gym before I self-quarantine. People will say, don't be a COVIDiot. We're also seeing a reckoning with the government's delay in the UK and now in America as well, and questions around the future global response as cases go to Africa and elsewhere. Next slide, please. So, quickly, COVID-19 is not only an immediate event. Its gravitational pull is going to be felt for years to come. It's going to influence geopolitical power between the world's two superpowers, China and the United States, which were already at an all-time low with trade wars and talk of conflict in the China Sea. There's a possibility, a very real possibility, of a Great Depression with ramifications across the global north, south, east, and west on the health of human bodies, but also the body politic. In an era of concerns about surveillance state, technology is being used to monitor the movements of millions of people. What effect will this have? COVID-19 is also revealing the changes in human microbial and ecological balances. We are in the midst of a sixth mass extinction on an unprecedented scale, with 100 million people predicted to be displaced by climate change in the coming decades. The risks of pandemics are only increasing as urbanization and other anthropogenic change drives more spillover from animals. COVID will not be the last one. And some Earth scientists have raised the question, is COVID a test run for climate catastrophe? In an interesting twist, nitrogen dioxide levels have fallen by 10 to 30% in China and 40% in industrial areas of northern Italy. Air pollution kills an estimated 1.6 million people in China every year. So COVID actually is worse in polluted air, seen as a confounding risk factor, as well as people with lung cancer, respiratory infections, and heart disease. And all of these are also linked to fossil fuel pollution. So in conclusion, we can ask, will COVID help us reimagine a more sustainable planetary health and a more sustainable global health? Only time will be able to tell. Thank you.
Thank you, Dr. Baldersh, so much for your presentation. I've also found it really interesting just looking at trends in social media around COVID-19 and how society is responding to this new environment. So right now, we'd like to use this time for the question and answer portion. So we've been monitoring questions throughout the webinar in order to direct them appropriately. Everyone, please enter any questions for the speakers in the chat below, and we can direct them accordingly. So the first question is for Dr. Fogel. So in those admitted to acute care or requiring ICU care, is there a difference in how they are being monitored clinically for normal practice?
I think the real challenge is at what point do you make difficult end-of-life decisions? And one of the things that we've had to deal with in our ICUs is we've changed the visitor policies so that families are not allowed to see their ill loved one who's in an ICU setting. I think the clinical management hasn't been necessarily that different than managing somebody who may have ARDS or be in septic shock. I think the hard part is the emotional aspect on both the staff and the families.
Thanks, Dr. Fogel. This next one is also critically directed towards you. What is your facility's practice in suspected COVID-19 patients who may be taking COVID? Are they contraindicated?
The literature on that is not clear. As a general rule, we're sort of recommending to avoid it. Again, there is no evidence basis for this, but there is certainly plenty of anecdotal evidence out of China and coming out of both Spain and France and Italy that it may be harmful. So it is definitely something I will not advise my patients who I send home to use. I tell them to take acetaminophen.
Great, thank you. So this next question is for Dr. Baldersh. Could you speak on the perceived growing mistrust of government healthcare organizations, such as the CDC's PPE recommendations by healthcare by HCP, and if there is any precedence for these in other pandemics? For you, Dr. Baldersh.
Thanks, that's a great question. You know, every pandemic or epidemic that I've been involved in, there's been a massive gap between the, let's say, the central authorities, medical agencies or government, and those on the front lines, including those in the community. And it's really important that recommendations acknowledge uncertainty, and where they're definite, they certainly acknowledge the possibility that these guidelines will change. The problem, one of the issues of what drives distrust is a gap between what people are hearing and what people are experiencing. And I mean, one key aspect of this response is it's really showing the importance of monitoring public perceptions and using that monitoring information to shape your risk communication and your guidelines. I think in regards to CDC, we have a massive public relations scandal right now. If you talk to the general public, they all know that the test debacle is CDC, FDA created. I mean, you have multiple news organizations from the Washington Post, the New York Times, Fox News talking about this. They've lost a lot of credibility around this issue, and to build public trust, it takes quite a long time, and it's easy to lose, and it's very unfortunate. So anyhow, that's one aspect of that. Yeah, I'll leave it there for now.
Can I just add one thing to that?
Yes, please.
Yeah. So I totally agree with what Dr. Baldersh had to say. I think one of the big challenges is, again, we have created policy to meet a supply chain. So if you go back a month ago, the recommendation would be that healthcare providers wear N95 masks. And now we have changed that to, well, they're not needed. And I agree that they may not be needed, but when the CDC changes its policy in this setting and is not transparent, it leaves a lot of people angry, fearful, and distrustful.
Also, just to pick up on that point, from a public standpoint, many people do not understand why health authorities are telling the general public not to wear some form of mask. If the issue is because we don't have enough of them, the people that I've spoken to feel like that should be communicated. That should be a request to the public, because people are looking at the numbers out of Japan, South Korea, Taiwan, where face mask wearing is culturally normative. And they're wondering why that's not being discussed. And in fact, some emerging epidemiologists are now starting to say, actually, this might help us if we're going to have these long-term lockdowns. So that's another important area of consideration.
Great. Thank you both so much for your response to that question. Our next one is regarding pregnant women. So are there any further details more specifically related to pregnant women and women in labor? There have been a lot of questions regarding women wearing masks while laboring. We'll direct this one to Dr. Fogel.
That's a difficult question, and I'll only answer what I know. And that is that for healthcare workers, we have made special accommodations or offered them to 3 groups of individuals within our practice, and it's actually fairly common around the country. If you're pregnant, you can try to avoid our areas where we're seeing, COVID-19 suspect patients. If you have comorbidities or you're over age 60, it's the same thing. It doesn't mean that those individuals are actually requesting or wanting those accommodations. I was working with a nurse last night who's due in May, and she's out there on the front lines. I don't think there's great evidence right now, but certainly it's reasonable to take increased precautions if one is concerned.
Great. Thank you, Dr. Fogel. I think we have time for a few more. It looks like the next 2 are both clinically based, and then one for Dr. Bardosh. So first, what can be done in clinical practice on med-surg floors to offload ICUs?
Well, we have created at our hospital just different units that when we hit what is conserved will open up mini ICUs elsewhere. Our concern down the line is going to be the issue of adequate number of ventilators and certainly adequate PPE. The big challenge for us may be if we run out of N95 masks and we are doing aerosolized generating procedures, are we actually going to go ahead and intubate those patients? Will we have respiratory therapists that will manage those patients? There are a lot of big questions, but I think most facilities have sort of created new units to handle the possible surge that we expect, but our volumes are all down. That's not necessarily the case in New York City. Their acuity is up, but they still have open beds. They just don't have enough ICU beds or ventilators.
Can you discuss what pandemic planning was in place prior to COVID-19 and why was this not followed?
That's a great question. I think it was October 2019, there was a large-scale U.S. simulation involving multiple layers of government. I believe Johns Hopkins University was really essential in that. And it simulated a similar type of pandemic situation. I've been involved in a number of these over the years with different INGOs. And another layer of this is after 2014, 2015, the West African Ebola epidemic, there was a lot of lessons learned about what went right and what went wrong. And there was quite a concerted effort to build capacity within the United States government to have an interagency a playbook, let's say, it is called a playbook, for a response like this. And after the Obama administration left office, they left a committee. I forget the exact name of this committee or group, as well as a playbook that could be used during a pandemic emergency exactly like this. When the Trump administration came into office, they disbanded the committee and they threw out the playbook. So I think that there's an immense amount of political drivers in terms of why these decisions were made late. Certainly, if you look at the Global Health Security Agenda, which is a worldwide effort to build pandemic preparedness, the United States ranks #1 in this score. It's called the JEEs, the Joint External Evaluations that are the WHO and other international agencies are involved in monitoring. And so, yeah, it's going to be quite a reckoning, I think, looking back at how the response was fumbled. But I do think that testing was really an essential component of this. If you don't know where the virus is, you can't build public momentum, political momentum to make the sacrifices that we're all now making to prevent it. So yeah, I hope that can partially answer some of that rather challenging question.
I'll add to that. I think we've had lots of false alarms over the years, and that would include everything from swine flu back when President Ford was in office to even, avian flu, a decade ago. And we all suffer from disaster amnesia, meaning we gear up, something happens, we throw lots of money at it, there's a lot of research going on, and then we forget things fairly quickly. I don't think we're going to forget this.
Thank you both. I agree. That was a really challenging question. Two really great answers for that. Unfortunately, we do not have time for additional questions as we're nearing the 1 p.m. Eastern Standard. But I'd like to extend our deepest thank you to our guest speakers for taking time out of their schedules to share their knowledge with us at this critical public health juncture. We are most appreciative to both of you. In closing, I'd like to say a special thanks to our colleagues in learning and development for their support on the production of this webinar. Please join us for the next webinar this Thursday, April 2nd, on mental health considerations for healthcare workers. We will be joined by Dr. Sonali Gupta, a licensed clinical psychologist and mental health psychosocial support consultant out of Chicago, Illinois, and Claire Whitney, a senior global mental health and psychosocial support advisor here at International Medical Corps. Thank you again so much to all of you for joining us. Our best to you, to your families, and to your colleagues. Take care, and we hope to see you on Thursday. Thank you so much.